All right. Hello and welcome, everybody. I am so excited to introduce you all to my guest today. This is Dr. Paul Rondestvedt, and he is a associate medical director at Ecumen Hospice. But he has had a long history in home health care as well as hospice. And we're going to have a nice conversation today where we kind of talk a little bit about different aspects and challenges that hospice agencies face with their documentation, doing CTIs, how to do appropriate IDT rounding as well. And so we're just so excited to have Dr. Rondestvedt here today. And Dr. Rondestvedt, why don't you go ahead and give us just a brief introduction and tell us your history. I know you have a background in emergency medicine as well, but fill us in a little bit on your history and what's led you to your current position today.
Yeah, thanks for asking. So I started out as a family physician in residency. I finished my residency but worked immediately in the ER where I had spent 2 years previously moonlighting. So I spent over 20 years working in a level 2 and level 3 emergency room, I never really actually practiced traditional family medicine. But after 20 plus years of weekends, evenings, nights, and holidays, I decided that I would like to make a change. And I was always interested in hospice, and I felt that a jump from emergency to hospice wasn't that big of a step because it's a chronic disease management center. You get to know chronic disease very well: dementia, cancer, COPD, heart failure. So it was really just learning the nuances and the conditions of participation under good mentorship, which I had. And I was easily able to make that transition without a fellowship into hospice. And I spent 4 years with the university system doing that until they sold their hospice and home care to a for-profit. And I left at that point and pursued other things for about 4 years until I returned to hospice with a different organization. So that's how I got here. Yep.
And you're also certified by the Hospice Medical Director Certification Board, is that right?
Indeed, yep. I didn't do a fellowship in hospice and palliative care, but I felt it was important if you're going to serve in that leadership role to really understand the conditions of participation. So I wholeheartedly embrace that, and I think that all people in our position, whether you're the medical director or an associate, should have that type of understanding. It just leads to much better compliance and much better leadership ultimately. Yep.
It does. No, that's wonderful. That's wonderful. Well, let's go ahead and jump in a little bit. So, one of the things that I often hear from other doctors, something that we talk about between different agencies as well too, is trying to determining prognosis as a hospice physician. So what do you find are some of the biggest challenges when you're presented with a nurse having gone out and doing an evaluation and you're wanting to determine whether or not to bring them onto hospice or not bring them onto hospice? What are some of those challenges that you experience?
So in my previous role, I had access to Epic, and I was able to use Care Everywhere, and I could really do deep dives. So I could get all of the minutia, the specificity, the sensitivity, the images, trending labs. I had really good insight into what the notes showed. I mean, you could get lost in a chart review, but I had access to a whole host, a whole ream of medical information, and I would always do that before the nurses went out. I have a template that I created where I did a deep dive and I figured out what do I think is the primary, related and unrelated conditions, and then I would write a clinic note that just says, hey, these are the things I'm seeing in the chart, to support them, to prep them, so that when they actually did the consult/admission, they weren't starting from zero. They were showing up saying, hey, we've had a chance to review your chart, and we've got pretty good information on your past history. So I empowered them to really have a good starting point. And I think that was helpful then. Now I'm still doing that in my current role, but I don't have access to that depth of medical records. And so that the limitations I have with the few things they upload into I have much less information to prep the chart, if you will, and to have a clinical sense of what's going on. So I don't have as much good information as I used to now. That's a big barrier, and I suspect that's true for many community-based hospice organizations. It's just lack of really good medical records. And frankly, some of the notes I see from different geriatric groups are appalling. They're really built, I think, for billing and coding, but not really painting a good clinical picture. I never see a FAST score or a PPS or a really good exam, and it's unfortunate. So I feel like I've got less to work with now than I used to. I still try to prep the nurses for success, I call it. A pre-look into a chart really does set us on the right course. And then we have to collaborate together and try to fill in the pieces once they go and actually do the bedside visit and get the information that's not in the chart. Eyes on, eyes and hands on.
Absolutely. Yeah, just like you said, like the LC or the FAST score and the PPS, which are both LCD criteria that Medicare is going to require that we provide for those patients, especially in a dementia patient with the FAST score. So I agree with you 100% because I think that it's very important to try and help set that nurse up for success in terms of, when a lot of our patients are extremely complicated, and so it's trying to help to determine like how to help narrow their focus, right?
Correct.
As a medical director, of trying to say, let's not lose the forest for individual trees, right? So because I don't want you to go look at this tree over here when we need to look at the whole overall forest, or we need to look at this side of the forest in order to help kind of narrow them down, because otherwise I think it can get very overwhelming because it's just two different training systems, right? Nurse
Yes.
training versus physician training are two distinctly different things. And they're both got their incredible positives, but we want to make sure that we use our strengths to help the nurses use their strengths. So I definitely agree
That's
with
exactly
you.
why I do it. I think if you look at a medical record, oftentimes there's a problem list, and the problem list is often duplicative, and a lot of things have sunset. It's a really garbage document, and I'll oftentimes see that they'll blow that into a hospice note, and that there's so much information. It's overwhelming. Whereas if I prepare a chart, I'll give you a brief example. I might say the primary is an ischemic cardiomyopathy, and I'll put related conditions include heart failure with reduced ejection fraction, EF 10%, stage 4 chronic kidney disease, depression. I might say unrelated hypothyroidism, gout because it hasn't been active in years, and history of whatever cancer because they're just sunset. So I put those unrelated, and I've got 3 specific criteria that says why I don't think it's related, and I've got that built into our charting. And so when they go there, they say, wow, I got a pretty good sense. This guy's got bad heart failure. He's got some anxiety that we think is definitely going to be affected or influenced by his terminal condition. And it gets them on the right path to ask the right questions. It tees it up. But if they look at that big problem list, there's so much stuff. Well, what's what? Is it CKD4 or is it 3A? Or sometimes you'll just get heart failure. Well, what kind of heart failure is it? Or what kind of dementia is it?
Yeah.
I mean, I can guess it's probably Alzheimer's in about 80% of the cases, but I like to see specificity in the charts I review, and I don't have, because I could take a deeper dive in the previous system I was on, I could find that now I'm just getting whatever they fax to us. Sure. So it's tough. Yeah.
It is tough. It is tough. Well, and especially, my agency here, we do a lot of patients that are in nursing facilities. And sometimes all they may get is a face sheet. And that's even more frustrating because then you have a face sheet, and that face sheet maybe has 15 or 20 different diagnoses that have not been updated in the longest time. And so you've got someone that's got both CKD stage 1 and 2, and you're like, wait, or CKD stage 3 and 4, or CKD stage and 5. It's like, well, which is it? There's duplicative and contradictory statements on here. So it can be really challenging. So I think teeing them up for that is perfect. Yeah. Now, in regards to that teeing the nurse up, I think it leads into, for us physicians, writing that certification to terminal illness report. Mm-hmm. But so often, when the more I've gotten involved in national agencies and things of that nature, and looking at overall and reviewing more charts, I see often CTIs are falling short in audits, especially in audit recovery. What are some of the things that you think are that make physician CTIs more prone to failing in audit?
Just lack of good information. When we don't have that really good information. So I created a document I call Monitor and Decline. And it talks about the symptoms, signs, and test results. And I'm specifically talking about the initial CTI, where I can really build a case where if I have, I've got these symptoms, these signs that tell me that there's been disease progression. These are the sort of tests that help to demonstrate that there's change. Maybe it's an elevation of the CEA. Then I look for nutritional, functional, and cognitive declines. You don't have to have them all, but we should at least look at those 3 buckets as well. And so I want specifics. I think it's important to be able to subjectively and objectively tell us what you see. If the weight's down by 6 pounds, there's a 1 centimeter arm circumference decline with continued temporal wasting, and the belt loop's now two marks tighter than it was 2 months ago. I mean, you can describe what you see. and I want some specifics. I would like them both. To your point,
Absolutely.
we
You know,
talked
in that
earlier.
in that same mind, Paul, like one of the things that I really like to focus in on is especially in regards to reduction in oral intake. So often I see nurses, they'll say, oh,
Yes.
they're only eating 30% or they're only eating 50%. Well, 50% of what? Like, did they go out to dinner and have like a restaurant quality meal and they ate 50% of that? Or did they eat 50% of a half a bowl of oatmeal? Because the two things are both the same, or both accurate, but which is it? And that's getting into that sensitivity and specificity that you're talking about, because I think it
Yes.
is so valuable to help paint that picture of decline.
Yeah, and once again, it's all based upon disease specific. So my dream was always to be a sort of a standardization. If you've got a dementia patient, these are the things we need to focus on as we describe and we care for them. If we have a heart failure patient, these are the things we need to describe and know what we need to know to care for them. Because it's also caring for people in the right way. And the more
Sure.
we know about the disease process, where they're at, the more accurately we can target their symptoms and manage their illness, right? So I
Exactly.
think it's important, and I look for certain things at the initial CTI. They oftentimes will get in the previous chart, but then I lose some of those. I'm not monitoring their tests anymore. I'm not following their PSA up. I'm not repeating echocardiograms. I'm not checking their creatinine once they come in. So if their GFR was calculated at maybe 18, so a low 4, almost a 5, I'm not going to check it in 3 months. So I need to find other clinical indicators that things are changing. But I can use that on my initial CTI to great value. So it's really just
Absolutely.
making sure the team knows what are we targeting in each of these different patient buckets. What information is important? What was then? What do we see now?
I
So
think
it's
that
really
that's
just
so
training the team
key.
what to look for.
It is. It's training the team what to look for, and I think though that this has to be done in such a way so that that the medical director is extremely present during IDT, and I think
Yes.
so often medical directors are not necessarily present during IDT. I think medical directors come to IDT and they say, okay, this is where I'm supposed to write my notes. And so they sit in IDT and they hack away at their keyboard 99% of the time, and they're listening, but they're not participating and they're not necessarily training. And I think that that's where we really have to change the culture. I think a lot of hospice, and so many hospices are employing 1099 contractors, and they're people that they've said, please come in, help us. You may be a large referral source for us. You're that person out in the community. You're a primary care doctor. You've got a lot of other things going on. We need you to come in and help lead our teams. But we're not necessarily always leading. We're sitting there being a passive recipient. But I think training the teams for those things is extremely valuable. And so I
Yes.
usually come to IDT with all of my notes templated and ready to go, right? So like I've read through all of the chart. We've talked about these patients previously on, we kind of teed them up during our last IDT when we knew that they were going to be up for recertification.
Yes.
I'm able to read through the ongoing nurses' notes. And so I have a general idea of what my nurse is going to say, and I'm able to put that into my notes so that then when I hear the note, I can ask any questions that I may have, or trying to dive into those and really hone in on those other features. But then that way I'm not sitting there typing the entire time, because that can be really distracting for the team as well too. So
Yeah, that's not participation. That's not at all. And I agree. I think that we talked a little bit about this before the meeting, but I think of IDT as having three different buckets of patients, like I said, and each has to have a very specific involvement of our team. There's the initial
yep.
certification, the new admissions, and I want to know specific things there. I want the classic elevator ride that gives me a thumbnail sketch from each of the disciplines. Help the team get started on the right foot. And then the recertifications are what did we see 2 months ago? What are we seeing now? What are the key features subjectively and objectively that we can put together as a team and say, this patient's declining and they continue to have a limited prognosis? And then there's the routine patients. That's a different conversation. We don't need to talk about decline. We need to say, what are we doing to take great care of these patients? What does our plan of care look like the next 2 weeks based upon what's been happening? So it's really,
Correct.
you have to be present for that, because you're trying to build a care plan. And what if the nurses don't know exactly what you're thinking? Hey, we've been hitting this guy with diuretics every 2 weeks. We're not making any headway. Let's talk about this. The guy's got, we've increased the Lasix. We've added metolazone. He's not diuresing anymore. He's got an EF of 15 or 10 2 months ago. This is likely a good example of, although this is not a clinical diagnosis, he's becoming diuretic resistant. He's not responding in a typical way. That is disease progression. I can put that in the note, that in spite of escalating and multiple different classes of diuretic, the patient is no longer diuresing as he's becoming more and more decompensated. I think this is the kind of stuff we should look for. And it's helpful because everybody's learning along the way. They're hearing the right words. They're hearing this. Hey, we're talking about a heart failure patient. These are the things I'm thinking about. This is how I'm tailoring the treatment. And I think this is that where you have to be involved. Otherwise, you're just reading notes. I can read your notes. Don't read your note to me.
Yes.
Tell me.
Exactly.
Don't
Yes.
read
Tell
notes
me.
ever.
Tell me what's going on.
Tell me.
Mm-hmm.
Summarize your note
Yeah.
without looking at it. You know the patient. Tell me. And I think that's what we try to do to keep people engaged. Know your patients. Don't read the note. We're all reading it together. That's a bad lecture. Everyone's falling asleep. But if you tell us and keep it dynamic, people are engaged. And it's important because these are people that really deserve great care. And we want to do that. But we need people engaged in the process, right?
Well, they do, and just like you mentioned about the diuretic resistant aspect of things going on there, right? A lot of the times our nurses may not recognize that, or they need that education, or they need that, maybe they're new to hospice and they've never experienced that before. And so they're like, well, what do we do in that situation? And like you said, bringing up to say, this is what you can expect, and this is how this is likely to transition, right? It's not definitively, I don't have a crystal ball, I can't predict the future, but I do know based upon my clinical experience that this is likely how things are to progress given the fact that this patient is in this state. And I think also tying those things back in, like you have that heart failure patient who has diuretic resistant edema, is third spacing everywhere, but they've also been having a reduction in their oral intake dramatically to the point that they're only eating a half a banana, and a couple of bites of oatmeal, and maybe they drink some yogurt. It's like, well, that patient's dealing with severe hypoalbuminemia. They have no liver synthetic function. They can't process protein in order to be able to even synthesize it. So of course they're leaking out. And no matter the amount of Lasix that we give to them or metabolism, there's no fluid inside of that blood vessel. It's all leaking out. And so I think teaching them that pathophysiology, now they're able to say, oh, now I get it when I go and see it. And then they can write that in their note. And then that all just comes together because now we have a really high quality note so that if we do get audited, I shouldn't say if, when we get audited by our Medicare auditor contractors, everyone's going to get audited. We have a defensible note because our nurses were well educated and well trained. So no, I think it's incredibly valuable.
Yeah, I think my dream would be if there was an EMR where you could, in hospice, that would just say, obviously there's multiple different diseases that come together, but in general, sort of templated or goal-directed. It says, hey, we're walking into a patient that's got cancer. What are the common things in squamous cell of the neck? I need to look for terminal hemorrhage. I need to look for obstruction. I need to look for these things. It really helps the nurse to be focused, ask the right questions, document what is pertinent, and not just rambling because they don't know what they're targeting. It saves them time. They come in with a very purposeful visit. They know what to chart, which is easy. If you know what you're supposed to chart, it just goes easier, and you know what to present. It's a time saver when you put the time up front to help develop these pathways or to help educate your team on you're coming into a patient with COPD. These are the things you got to look at. These are the things you got to ask and just chart those things. The rest of the stuff is superfluous. I don't want to hear about the dog or the neighbor or they tripped on the rug necessarily. But you know what I mean.
I do. And Dr. Rondestvedt, I think you totally set me up there as well, too. As you know, we're building hospice intelligence, and we're not an EMR, but we're a tool that works outside of your EMR that you can then bring that in. And that's one of the things that we're really focusing on is trying to help to set that nurse up for those types of things. We're working on we're validating our physician module right now, and that should be being released in the next at the end of this quarter to beginning of next quarter. And we're really excited about that as well too, because it really gives you the tools to reduce the bandwidth on your brain, because we're being pulled in so many different directions. We're being pulled from nursing staff, needing, meds changed, or we need to talk to a family member. We have a care plan meeting over here. And so the time that nurses and physicians have in order to document and dictate is shrinking and shrinking and shrinking and shrinking. And in all honesty, that's okay. I would rather have my team spend more time at the bedside. But what we want to do is I want to make that as easy as possible to be able to document to. And so having those reminders to say, hey, you should be looking at this and you should be looking at that. That's one of the things that we're building into our decline tracking modules right now, is that when we're looking at cert period, 2 to 3 or 5 to 6, what has changed over the previous cert periods, and what can we look to go into that note to appropriately write. So what kind of functional changes have the patient had? What kind of dietary changes? What kind of cognitive changes? Are we hitting all of those LCD criteria? Because I think that's what helps to really build in the good note. And if we can do that on the front end, as opposed to trying to do it on the back end, we're going to be far more successful in that regard. So,
yeah, I think that's exactly what the space needs. You need to ask the right questions, have the right intelligence up front, and then chart to that. That's just good care. That tells you that you know how to laser focus on what is pertinent to this particular patient. Document that, and the rest will follow. You'll do better care. Your documentation will be more succinct to the disease process. And then when it comes time for that recertification, you've got the right things in place. You can show that there's been functional, nutritional, and cognitive declines, or some combination thereof, right?
Absolutely. Absolutely.
Yeah. So you got to know what you got to, you don't know what you don't know, but if you're given good tools, good success setup, right? It's like evaluating a patient before the first visit, so the nurses are set up for success. And you might change a few things around once they're there, but at least they have a roadmap to start with. And if the AI builds a roadmap into asking the right questions and document what truly is pertinent, you're also not being repetitive. I don't need to hear you say that they're losing weight 4 different ways.
Yeah.
You built in MAC is down, weight's down, and their clothes are far looser fitting than they were 2 months ago. Boom, you just built the picture that's pretty much defendable at any point in any way. You can say, look.
Oh, absolutely. There's no way that someone could say that patient's not losing weight when you're able to spell it out in all those different categories. It makes it very clear. And I write a lot about this on social media and LinkedIn and on my blog, but it's really helping to paint the picture, because we have to paint a picture of decline, because the people that are auditing our charts, unfortunately, they're not medically trained. Some of them might have some clinical experience. They clearly get some experience or some clinical understanding of things, but they don't have the clinical understanding of a nurse or a physician. And so they need to be having a clear story painted, and that needs to flow from beginning, middle, to end. And it needs to paint a very clear trajectory and picture. And I think that that's something that a lot of people struggle with, because nurses and doctors alike, we're not, most of the time, we're not English majors, we didn't, we took the necessary English requirements, but we're not necessarily writers per se. And I think that's what you have to sometimes make sure that you're clearly delineating those facts that you see. And sometimes it's hard for people to capture those things or write them all down. And so that's what we try and do at Hospice Intelligence.
Yeah. And it's a good point too. And it reminds me of something that I always try to remind the team, is that you're documenting decline in certain notes, but not all notes. So we're doing two things. We're taking care of patients and knowing how to specifically target and manage their symptoms, right? And we're also trying to be acutely aware that the disease is progressing and that they continue to meet criteria. So we have two different roles that are, as you said, there's a lot of noise when you come in. So what hat am I wearing today? Is this
exactly
the plan of care I'm working on, or is this, am I now comparing, because it's been 2 months, to see what kind of progress has this patient made to suggest decline? And I always remind people too that you can be audited, but if somebody is a fast 7F, a PPS of 20, who needs total assistance, there's not much more to decline. You're talking microscopic decline, so you're not going to see a 1 arm circumference decline. You're not going to see 5 pounds of weight loss, but you're still going to recertify this patient because there's nowhere to go but death. So how do you sort of discreetly describe that, right?
I think that's one of the greatest challenges that we have, and especially I think it comes into, why is that patient still surviving, right? Are they surviving because they have a feeding tube, for instance, right? Yep. And so then that comes down to, are we showing any signs of aspiration? Are we choking? Are we coughing? Are we having reflux signs? Can we reduce the tube feeding? Are we reducing our, unnecessary medications? Are we having those appropriate care plan discussions with the patient, family, staff as well too? I think that it all comes together, but you're so right, because you want to continue to provide service, and we don't want to do discharge for extended prognosis for that particular individual because the patient doesn't really have an extended prognosis. We all know that their prognosis is death. That's very clear from a medical perspective. But if we're not showing those declines, then it becomes very challenging. So looking at those things that are not necessarily easy or obvious to pick up. And I think that's where, again, going back to leadership from a medical director perspective, I think is so key. And if your medical director isn't engaged in that conversation, then that nurse may or may not know what to look for, especially if I can think of a brand new, fresh hospice nurse who is given that patient with the PPS of 20% and a FAST of 7F, and they're like, what do I do? I've never seen a patient that looks like this before. I came from an outpatient oncology clinic, for crying out loud. I never saw this type of patient. What do I do? And so I think that we really need to be clear in regards to helping to educate those people and really spending the time because, like you've said so many times throughout the interview, this is a Medicare benefit. This is something that these patients have worked their entire life for. They have paid into this system and they deserve their benefit and they deserve that extra help. They deserve the extra care. They deserve the home health aides. They deserve the social worker. They deserve the chaplain. They deserve the massage therapist coming in and helping them. And we want to make sure that we continue to provide that. So our documentation allows for that.
Correct. And I think our documentation, in my mind, reflects our professionalism. Do we really understand this patient? I know we're documenting decline in the CTI, but if we really have a good handle on what's going on, in my mind, that translates, we also know how to take care of this patient. So the two 100%. Really go hand in hand. I think my theory is a patient well charted is a patient well understood and cared for. And a patient that's poorly charted makes me wonder. They could have got great care, but I don't know that because I don't have any evidence of that.
Very true. Very true. And it makes you wonder, do we know? Yeah. And if you're not saying what they actually ate and you're just saying that they're only eating 25% of the meal, do we know what that actually means? Have we ever observed them eat? So I think you're right. And I think that's what the Medicare contractors are looking at too, is they're saying, if your documentation isn't supporting this, how do I know? So I agree with you. This has been so fun, Dr. Rondestvedt. I really, really appreciate your time, your expertise, and I know that the patients with Ecumen Hospice are extremely lucky to have you, as well as the nursing staff and the executive administration there. So we're so grateful for your time.
It's a blast to do because the people deserve it, and it's great to work in a team. It really is. It's energizing to work around great people who care.
It is. I love IDT. Yep. It's one of my favorite parts of my week. It really is getting to spend time in IDT and talk about the patients and educate. And it does. I come out of IDT energized. And I think that if you're not coming out of IDT energized, it might be a lot of work and you might be a little tired, but you still have your cup filled and said, I know we provided good care. I hope that's how most people are coming out of it filled. So.
Yeah, and that's why it's important also to build your IDT around that success, right? Those 3 buckets of patients. 100%. And how we present them and how we talk about them and to keep the energy moving.
Absolutely.
A good lecture, the lecture just disappears. A bad lecture, it takes forever, right? So that's our goal. How can we run that show? We're the pace setter. We're the pace setters.
We are. Yep, 100%. 100%. So, well, awesome, Dr. Rondestvedt. Well, again, thank you so much for your time, your energy, and clearly your passion for this service. I really appreciate it.
I appreciate it too. Thanks for the time.